Okay, I'm going to let Rob introduce you today. So again, thanks for doing this, and
a real privilege. Thank you.
Hope to see you in person sometime soon.
I would love that.
So we're probably going to have some more people trickle in, but it's just after 8 o'clock, so I think we can get started. So today we have Dr. Jonathan Liebseck, who's a professor of radiology and cardiology at University of British Columbia. He's the regional department head of medical imaging and a past president of the Society of Cardiovascular CT. He's a Canadian research chair in advanced cardiopulmonary imaging. And in 2019, he was one of the top 1% of researchers. He has over 525 peer-reviewed publications with an H factor over 79. And today he's going to be talking to us about cardiac CT for coronary artery disease, from diagnosis to PCI planning. Thanks again, Dr. Liebseck, for coming to join us today. Looking forward to it.
A pleasure. Thank you so much for having me. Obviously, many friends and collaborations with your great division, particularly mentorship and guidance as we install our 3T CFI magnet from James and the team as it relates to Andrew and the cardiac MR side. So really, I look forward to stewarding deeper partnerships between our imaging divisions and especially in the cardiac imaging space. So without further ado, this is the title of my talk. Obviously, it's a broad talk. I could focus on any number of things really, including atherosclerosis and what CT has taught us around plaque progression and beyond. But I'm going to try to focus in a pragmatic approach. First, why I think CTA should be considered the first-line test for patients with symptoms of possible coronary disease, but not yet confirmed coronary disease, and then work our way through how CTA can move from a diagnostic tool to a tool to actually plan coronary intervention in a fashion similar to how we use CT in structural heart disease. I do have disclosures. I run a CT core lab that supports a lot of the structural heart work in the aortic and mitral valve space. I take no compensation for that, but I do receive grant support from GE Healthcare, and I am an advisor to HeartFlow and have been so for the last 3 or 4 years. So that's obviously salient to this talk. So, I get accused also of having the need for another disclosure, and that is that I'm a CT zealot. And, I think it's probably fair. I am very zealous about the opportunities afforded by coronary CT, but I think it's because it helps me answer most of the questions that my clinical colleagues are asking me as it relates to specific set of patients. So, I wouldn't argue that we should do cardiac CT in a patient where the clinical question is, what is coronary flow reserve? Or is there a regional wall motion abnormality at peak exercise? But I do think that if the question is, does the patient have or not have coronary disease, it makes a lot of sense to me to explore the non-invasive, safe opportunities to anatomically evaluate the coronary arteries with CT. And when you think about it, the opportunities for CT have really grown over the last 35 years. Obviously, they started to grow by the fact that we could actually do it. That was first and foremost the most important thing. But beyond that, we've seen a real shift in the patients that we're serving. For those of you that have practiced, over the last generation, I'm sure you can attest to this. And in fact, from the Confirm Registry, which we participated in, a paper led by Dan Berman and Victor Chang back in 2011, we were the first to actually highlight that the patients we were seeing in the CT lab did not have the disease burden that would have been predicted by traditional Diamond and Forrester. And to highlight that, what we found was that approximately the pretest likelihood of stenotic coronary disease in the Confirm Registry was 54%, and yet the observed rate of stenotic coronary disease in the Confirm Registry was only 16%.
Is Kevin?
I don't know how available he is.
So people were critical of that paper, suggesting that we didn't adjudicate symptom status as robust.
You mean he's going to be on the island but not available?
I just don't know, dear.
People go on mute. I'm sorry.
We don't.
Jonathan,
Please,
going to ask
I knew
people
he was
to
on
mute.
Wednesday,
Please mute.
to work,
Can you
but,
please mute? Sorry,
pray to
No, I'm
God,
sure he'll.
guys.
okay.
I think it's
Well, I mean, let me know.
Dr.
Paul,
Armstrong.
there you go.
Armstrong.
Thanks.
There you go. All
Maybe
right.
Paul, you can mute. Sorry about that.
Oh, that's okay. Hey, this is the nature of the beast, as they say. But I would say that, you know, while people were critical, including Dr. Diamond, may rest in peace, of our manuscript, I think what we highlighted was the first insight into the fact that the patients we're serving when we're doing non-invasive testing are clearly not those patients that were going to the cath lab in the early 80s. And why this was surprising to people, I don't know, but this has been reiterated recently in the stable ischemic heart guidelines, or chronic angina, chronic coronary syndrome guidelines from the Europeans. This is from Johanni Canuti in their guideline document in 2019, highlighting that when we see 60-year-old males with atypical chest pain, the pretest likelihood of stenotic coronary disease is not 65%, as would have been predicted by traditional Diamond and Forster, even modified Diamond and Forster, but more like 25%. So for those of you that are in the clinic seeing patients with de novo symptoms of possible but not yet confirmed coronary disease, my hat goes out, you know, my hat is taken off to you as far as how challenging this is, because the disease burden is far too extensive to simply ignore, but yet far too low to simply obviously refer to the cath lab. And so, you know, we look at the current guidelines in the United States, which I'm told will actually be iterated in September, although it's been pushed off twice, so I wouldn't bet money on it yet. But if we look at the traditional assessment, you can appreciate that it's quite a circuitous approach to the diagnosis of coronary disease. And I say that not because I don't think that stress testing plays a role in modern, obviously, practice. It will continue to play a tremendous role, particularly the great stress CMR work that you guys do in Calgary, the PET work that's done by so many. But I think that if the question is there atherosclerosis in the coronary arteries, and is there an anatomical stenosis, you can appreciate that this assessment that relies on clinical symptom status, that's largely age, sex, gender, ethnically, and even climactically biased. You know, the concept that a woman who speaks English as a second language, who doesn't tell you the same history as an older white male coming out of a restaurant in a snowstorm in Boston, that she can't have coronary disease, is, how do you say, probably not correct. And then traditional non-invasive stress testing, which we know provides us important information, but I don't think it really helps us adjudicate the presence or absence of coronary disease. We've seen that in the NCDR database, where 63% of patients go into the cath lab in the US, despite 80% having stress testing before, are not found to have actionable coronary disease. We've seen pitfalls as it relates to the adjudication of left main disease. And even recently in the ischemia trial, we've seen that up to 20% of patients with moderate to severely abnormal core lab adjudicated stress tests do not have stenosis greater than 50% at the time of their CT, which was used to screen these patients. So again, I think stress testing will continue to play a role, but I don't think it will be for this purpose. Because as mentioned, I think not only have we seen the data, but at least every day when we do 25 coronary CTs, we hear the same story. We hear these atypical or typical angina symptoms, patients that have had stress tests, and the stress tests are either normal or equivocally abnormal, and what we find when we do the CT is either high-grade anatomical disease, but we're equally likely to find no plaque whatsoever, or mild plaque, or sinister stenosis and aggressive adverse-looking atherosclerosis. So the first reason I think we should consider CT as a first-line test is that as an anatomical test with all its warts and limitations, it nonetheless has superior diagnostic performance characteristics as it relates to the invasive gold standard. These are data from 4 studies that go back over 13 years. These are 64 slice CT analyses that are now historic. The data is, if anything, improved, particularly as it relates to the specificity and positive predictive value. But you can see that if you're to evaluate someone up front, and the key is to exclude stenotic coronary disease, the negative predictive value is obviously unparalleled. In addition, when we look at the opportunity to not only exclude stenotic coronary disease, but exclude atherosclerosis, as we know, there's no real meaningfully non-invasive test that can actually provide you a sense of the extent and severity and morphology of atherosclerosis, which we know is incredibly powerful in its prognostication and an ability to help guide personalized titration of medical therapy. More modern data, and this comes, the analysis was led by John Mancini, my colleague, but we, along with Jim Min and Matt Budoff, were the CT core lab for the ischemia trial. And so we had the opportunity to read a number of CTs prior to patient enrollment. As you probably remember, the CTs were done in a blinded fashion to exclude left main disease, to allow for enrollment, and to confirm the presence of stenotic coronary disease. And I know your site enrolled many patients. And so what we saw was the agreement between invasive coronary angiography and CT was incredibly high as it relates to the absence of left main disease and the presence of anatomical stenosis, 97.1% agreement. So obviously the agreement is not 100%, and CT has limitations. Obviously, you need to prepare your patients well, you need to give nitroglycerin, you need to give beta blocker, and you need to optimize image quality. But even in the setting of very complex CAD, in the modern setting, the agreement between invasive angiography and CT was very high. So people will tell me, maybe 15 years ago, I would give this talk and I would really show them these anatomical images. And, I'm just a simple radiologist. And I would see these images and I would think to myself, if this doesn't change the way people practice cardiology, I don't know what will. You can suddenly see plaque. You could see a stenosis in the LAD rather than giving someone a post-test likelihood of anatomical disease. But, people rightfully at that time said to me, Jonathan, pretty pictures are nice, but at the end of the day, I need to do additional stress testing because I need to really understand the prognostic impact of these findings for my patient. Now, I could give you, I wouldn't, but we could talk, I should say, that was a bit arrogant. We could talk about the prognostic utility of cardiac CT for an hour. There are endless manuscripts that have looked and explored the prognostic utility across various populations across the globe. But I'm going to share with you two slides that I think really drive home a lot of the key incremental components or the value that's brought forward by a coronary CT as it relates to risk prediction. One is from the PROMISE trial. The PROMISE trial was published in New England Journal in 2015, where 10,000 Americans were randomized between CT testing versus functional testing. And the sub-analysis was performed by Udo Hoffmann, formerly from MGH, published in Circulation. The x-axis is time, the y-axis is the percentage of patients with events. And what you can see here nicely is those patients bereft of atherosclerosis by CT, the event rate at 3 years was just over 1%. That was 60% lower than a negative SPECT. So that the negative predictive value for event is significantly lower. And as we've seen in longer term follow-up, the warranty period is much longer than traditional stress testing. In Dan Berman's lab, they provided a warranty of roughly 2 years of a negative SPECT. What we've seen in CT is the warranty period, if you have a truly normal, clean CT of good quality, the warranty is somewhere between 7, 8, 9 years. In fact, recent data, 10-year follow-up. So I think the negative predictive value, the lower event rate in the setting of negative CT, and the warranty. The second thing that you could see here is that uniquely, CT allows you to discriminate those patients with plaque, but no stenosis. So these are these mildly abnormal patients. These mildly abnormal patients without stenosis, but with atherosclerosis, have a threefold hazard for incident event over the following 3 years. When we looked at the confirmed registry, this is exactly the same event rate we identified. And people were critical of that. They said there was ascertainment bias. But the reality is, if you have the disease that causes incident myocardial infarction, you're at higher risk of having major adverse cardiovascular event than those patients that have no CT evidence of atherosclerosis. On the other hand, when they looked at the SPECT data, those are the mildly abnormal SPECT, and a normal SPECT had the same downstream outcome. So I would posit to you that there's a real opportunity to really personalize medical therapy when you have when you have undertaken CT for investigation of your patients. If you have two patients, one with plaque, one without plaque, waiting for you in your waiting room, the one with plaque, I think you could make an argument, especially if it's premature, if it has adverse risk features, or if it's more extensive than you would expect, that patient needs more aggressive medical therapy. On the other hand, if you have two patients with a normal or mildly abnormal SPECT, and they ask you, doc, should I take this medicine or not? You really have to rely on population-based risk to titrate medical therapy. And as we've seen from the Scott Hart trial, you don't die of risk factors, you die of the disease. And so, treating strictly on the basis of the risk of disease is obviously less, I would posit to you, less robust. Finally, let's look at the relative risk of someone with a severely abnormal stress CT. The relative risk is tenfold. This is partly due to the fact that the absolute risk of a negative CT is very low, but also the fact that if we call a severely abnormal CT, we call it triple vessel or left main disease, it's possible, certainly, that the patient would go to the cath lab and be found to have 2 vessel stenotic disease, maybe even 1 vessel stenotic disease. But it would be source of an M&M discussion if you did not find stenotic coronary disease in a single vessel, full stop. On the other hand, as we saw in the ischemia trial, amongst those patients with moderate to severely abnormal stress tests, when we did CTs, 18% of those patients did not have a stenosis greater than 50%. And as a result, the relative risk of a severely abnormal stress test, at least in PROMIS, was only 3.8-fold. So I think these are some of the key elements that have really opened our eyes to the opportunities of using CT not only for diagnostic purposes, but for prognostic purposes. Finally, just more contemporary data. This was presented by David Marin at the virtual ACC last year when he looked at the relationship between the extent and severity of anatomical disease by CT and the extent and severity of stress testing abnormality. This is a very similar analysis to an analysis John Mancini performed back in 2014 from Courage, where he showed the extent and severity of anatomical disease by ICA was powerfully prognostic and was prognostic beyond the stress testing findings. But in this case, the anatomy is not from cath. The anatomy is from CT, and we see the exact same thing. The extent and severity of anatomical disease by CT exhibited a strong relationship for mortality. The extent and severity of stress testing did not. So I think that CT, again, in patients without known disease in particular, provides us a real opportunity to prognosticate by the unique opportunity to identify non-stenotic plaque, as well as adjudicate the extent and severity of anatomical disease. Now, I elected not to spend a lot of time about plaque, but, we could also have a whole discussion about what CT has taught us about plaque, and there may be many people that would do that talk better than I, and I would welcome you to invite them. But certainly we've explored this a lot as it relates to plaque morphology, the extent of plaque, and what we can learn from it. And recently, we've seen a number of papers that have come out that have highlighted that CT not only offers you an opportunity to identify stenosis, but the number of segments of plaque, the overall semi-quantitative assessment of the segment involvement score, which provides us an assessment of overall plaque burden, and then plaque morphology, very similar features that have been noted on IVUS, and intravascular imaging to connote high-risk morphology, such as positive remodeling, low-density plaque, spotty calcium, and a napkin ring, where you have peripherally higher attenuation and centrally low attenuation. The SCCT came out with a guidance document just in January this year. And what we tried to highlight is that CT is not yet ready for automated quantitation of plaque. And there are limitations with regards to acquisition in order to try to serially follow up CT, that patients need to be imaged at the same tube energy, and the blood pool has to be very similar. Otherwise, you can distort the overall elements of plaque. But that in the modern practice, we should be doing more than just reporting stenosis. We should report the number of segments of involvement. We should report patterns of plaque vulnerability. We should discuss if there are high-risk plaques. And I think the opportunity with AI and machine learning to get more elaborate quantitative plaque measures in the future are real. Now, there's been a whole compendium of data that have been shared with us over the last decade, starting with Sadako Motoyama and Jagat Narula's work in 2007, highlighting that the same features identified on IVUS that helped identify patients at risk, so-called positive remodeling and low-density plaque, are predictive of downstream events. We found the same with CT. And in fact, CT has, I think, expanded our understanding of this by really highlighting a couple of things. That non-stenotic plaque is bad because it's bad if it's left unchecked. If patients exhibit plaque progression, they're at an increased risk of incident myocardial infarction. What we've also seen is that patients with these high-risk plaque features are more likely to experience incident myocardial infarction downstream, but are also more likely to exhibit plaque progression. So coming full circle, we know that high-grade anatomical disease is associated with the highest risk. So the message from all of the CT data, similar to John Ambrose's work from 30 years ago, is that it's not that high-grade stenoses aren't relevant. It's that non-obstructive plaque needs to be treated. If not treated, it leaves the patient exposed to to plaque progression and therefore incident myocardial infarction. From the ICONIC registry, where we took 234 patients with a confirmed myocardial infarction and matched them to 234 patients within the confirmed registry, matched for sex, risk factors, and quantitative plaque measures, what we saw clearly is those patients that experienced incident myocardial infarction had a higher burden of non-calcified fibrofatty and necrotic core. So very similar to the IVUS data, biomarker, or sorry, an imaging marker of risk that can help us understand and refine our understanding of risk on a per patient basis of incident myocardial infarction. So moving away from atherosclerosis, before we move into physiology and planning intervention, I would highlight to you that the other reason I really think CT should be considered a first-line test is that there's reasonable data that would suggest that guiding medical management on the basis of the results of CT can improve clinical outcomes. These are data from David Dubey and the Scott Hart group, where they looked at 4,000 Scots men and women randomized between traditional care and CTA. And what they found was that patients who were randomized to the CT strategy had a 40% lower incident myocardial infarction rate and cardiovascular death rate. Now, people asked David, how is this possible? The absolute difference in statin utilization was only around 35%. And smart people like Sanjay Kaul wrote, editorials in JAMA Cardiology saying that the treatment response to that absolute difference in statins, just, the 40% reduction is beyond what one would expect. But I think what people didn't realize is that the absolute difference between the 2,000 Scots men and women who were imaged by CT and those that had just treadmill testing, the treatment response or the difference in statin usage wasn't just blindly done in the CT arm. And I think therein lies the power. This is from a paper published by David's group last year in JACC. And you can see here the x-axis is the 10-year assigned risk score, population-based Scottish risk score. The y-axis is the percentage of patients with events. And you could see here in gray, those without plaque, purple, those with mild stenotic plaque, and those with stenotic disease in orange. And you can see that the Scottish cardiologists were quite thoughtful. They said, listen, if you have plaque, even if my risk tool tells me, hey, you shouldn't have plaque, or maybe you shouldn't have an event in follow-up, but you have the disease that if left unchecked and if left to progress rapidly may expose you to a risk of incident MI, they treated these patients. On the other hand, if they had no plaque, even if they had a higher population-based risk score, the likelihood that they were being treated with statins was much lower. And usually when they were, it was because they were younger patients who may not have had plaque, but obviously it may reflect their younger age, and the cardiologists were not willing to down titrate medical therapy. But I think this slide really highlights the opportunity of CT-guided medical therapy, treating the actual presence or absence of disease rather than the risk of disease, because as we always say, you don't die of risk factors. I'd rather have every risk factor in the world, of course, and no atherosclerosis. It doesn't help me if I have no risk factors and a truckload of atherosclerosis, because I'm at risk of obviously incident myocardial infarction and death. So I think for all of these reasons that CT is highly accurate anatomically, it uniquely identifies plaque, it's powerfully prognostic, and allows for the personalized titration of medical therapy in a fashion that reduces incident MI, that the Europeans 2 years ago came out with a class 1 guidance, and in fact suggested that CT should be the first-line test for the majority of patients without known disease, except for those at a very high pretest likelihood. But when you look at the risk calculator, you have to be over 70 in a male with typical angina to have a pretest likelihood of over 50%. So I would posit to you that the Europeans have really leaned in to a CT first strategy for patients without known disease. Now, while I think that's, sorry, I don't, hospital computer. Well, I think the data are compelling and I think have supported my enthusiasm. I was always stopped in my tracks, so to speak, as it relates to answering this question, right? Because if I had a moderate lesion in the mid-LAD, 50 to 70, or even 70 to 80% non-osteal LAD, and I sent it to my interventionalist, she would rightfully say to me, should I revascularize this patient? Or my clinical cardiologist may say the same thing to me. Patient has moderate coronary disease, should we revascularize this patient? And they were right to ask me that question because, of course, as an anatomical test, we know that the totality of randomized data to date does not support revascularization on the basis of anatomy alone. And we know that the gold standard for guiding revascularization is invasive physiology, whether it's instantaneous wave-free ratio or hyperemic fractional flow reserve. This is data from the FFR trial FAME2, where patients with abnormal FFR, defined by a threshold of 0.8 or below, were randomized between medical therapy versus revascularization. This is a 5-year outcome data. And you can see that those patients who are revascularized experienced a 73% reduction in urgent unplanned revascularization, and also a 35% reduction in myocardial infarction, highlighting that if patients have anatomical targets and abnormal physiology, they appear to derive a significant benefit from revascularization. These data are not only found in the randomized trials, but actually recently last year, about a year ago to the day, in fact, published one in the SCAR registry, which is a Swedish national registry, and one from the Northern California VA on the right, that patients revascularized guided by physiology had lower mortality than those revascularized by anatomy alone. Now, this is observational data, and obviously there are many potential drivers of this, but I think the message is consistent, right? That anatomy alone doesn't really allow you to inform revascularization. I think that's one of the limitations of, frankly, the ischemia trial, that many patients were revascularized solely on the basis of anatomy, despite having non-invasive stress tests, very little provision of physiology, and that when patients are revascularized by physiology, they seem to do better. And that final slide that I'll share with you to that end is data from our great country, from Ontario. This is work from Harindra Wajisundra from Sunnybrook, from the OMCAS registry. What you could see here is not only does abnormal physiology, are we able to identify patients who derive benefit from revascularization, but the corollary, the opposite holds true. By revascularizing those with physiology above 0.8, you actually derive harm. So it's, I think therein lies the real opportunity, not only to up-titrate revascularization in those with abnormal physiology, but to leave alone those patients who have physiology that's not in the abnormal range. Of course, to have to do this invasively and make these decisions ad hoc is always challenging. And so about a decade ago, I was first exposed to the opportunity of using something called FFRCT, where you could derive a pressure map from a resting CT. Before that, for those who are not familiar with this disconnect between anatomy and physiology, I would just highlight to you that whether you have anatomy from QCA or anatomy from CTA, there's an inconsistent relationship between that anatomy and physiology. That sure, patients with severe lesions are more likely to have abnormal physiology, but roughly 1 in 4 70 to 90 lesions have physiology above 0.8, hyperemic physiology above 0.8, and about 1 in 4, 1 in 5 lesions in the 40 to 50% range have abnormal physiology despite the lack of a focal high-grade lesion. So can CT provide you one physiology and anatomy in one test? And so again, about a decade ago, I was exposed to this concept of actually extracting the anatomical boundary conditions from CT and then the application of computational fluid dynamics without a change in protocol, without medications, and without rescanning the patient. Now, clearly, I don't have time to delve deeply into the science behind it, but the field has really evolved over the last decade, and I'm sure you're working in many areas around AI, but the anatomical segmentation has become much more robust and much faster and reproducible through AI-based segmentation of the anatomy. And once the anatomy is segmented and extracted, suddenly all the form-function relationships that can be extracted and applied to the coronary tree are applied to the CTA, whether it's integrating the size of the coronaries, which are inversely related to microvascular resistance, the thickness of the heart muscle, which provides you a measure of resting flow, the fact that blood is a Newtonian fluid, so that all Newtonian fluids are governed by the so-called Navier-Stokes equations, and therefore computational fluid dynamics can be applied to the resting CT with virtual and computational hyperemia applied. Now, when you look at how FFRCT performs, it's important to understand its strengths and limitations. Over the last 3 accuracy studies, the accuracy compared to invasive FFR is about 87%. You could see in the Pacific trial, it surpassed oxygen-labeled water PET, CTA, and SPECT. But I think the real opportunity as we pivot to clinical utility and guiding PCI is that if you do a CT, FFRCT pathway, you don't just provide anatomy and you don't just provide a surrogate measure of physiology by way of this PET, but you actually allow yourself to send the patient to the cath lab with a roadmap of the anatomical lesion length, the morphology of the plaque, perhaps provide fluoroscopic angulation, the translesional pressure, and the physiology. Whereas if you send a patient, of course, to the cath lab with an abnormal PET, you could tell your interventionalist that she's likely to find an LAD lesion, but not how long the lesion is, where the lesion will be, whether she needs to be prepared for lesion preparation and rotablation or not. So I think therein lies the real opportunity of CT and then limited use of FFRCT when needed. Now, how do we interpret the data? What we learned over time is that when we unmask our FFRCT model, it doesn't come out with an answer, positive or negative, but really it provides us an opportunity to extract pressure across the coronary tree. And what we've learned is that there's 2 important values, one distal to the stenosis. This is the value that we use as it relates to guiding decisions around cath lab referral. If this value is above 0.8, we defer catheterization. If it's below 0.75 or 0.75 or below, we refer for the cath lab. If it's in the gray zone, we look at things like the translesional pressure loss, how much pressure is lost across the lesion. We look at the plaque morphology as well as the anatomical location. Now, people will ask me, what does this 0.70 mean? Well, what this means is this patient is not well, right? Johnny Goudreau would not have an FFRCT value. I've never imaged him. I'm not breaking FIA, and I know it's recorded. But he would not have an FFRCT in his distal LAD of 0.70, right? This is a reflection of poor vascular health, typically poor vasodilatory capacity, low coronary volume to mass, or diffuse plaque. But this value is not a value that should be used to guide decisions around cath lab referral. Further to that, our friends at Cedars looked at this. They looked at patients and they quantified plaque using AutoPlaque, the tool that they've developed there at Cedars. And what they found was that patients who have low nadir FFRCT values had more quantitative plaque. So again, this nadir value is very important as it relates to a surrogate measure of vascular health, but is not a value that can be treated by sending the patient for focal percutaneous coronary intervention. So again, this is how we report it. We look at the value distal to the stenosis. If above 0.8, we defer. If below 0.75, we refer for cath. And if in the gray zone, we look at the translesional delta. If there's a significant focal delta of pressure loss, we're more likely to refer to the cath lab. If it's proximal, and if there's adverse plaque. And you may say, well, why do we integrate plaque? What does plaque have to do with it? Again, there's a whole compendium of data that would suggest that plaque and physiology are interconnected. In fact, there's good data that would suggest that if you have adverse plaque, you're more likely to have abnormal physiology. About 4 or 5 papers that have explored that in the literature, plaque by CT. And there are many people who posit why that may be. Maybe poor local vascular health, inability to locally vasodilate and accommodate hyperemia. But beyond that, we've seen very interesting data. This is from a study called the FRIENDS study from Akasaka and Professor Ku from Japan and Korea, where they looked at patients in the gray zone of physiology, sort of that 0.76 to 0.83. And what did they find? Hyperemic pressure in that range, that if patients had abnormal plaque on CT, that their downstream event rate was significantly higher than patients with lower FFR, but without those features. So it really highlights a threefold difference when you're in that same range of physiology if you have these adverse plaques. So imagine now if you had that physiology non-invasively and you could explore the plaque. It really helps you then refine your understanding of who's potentially at risk and who is going to derive benefit from revascularization. Now, how has this tool impacted clinical decision-making? What we've seen is that by layering FFRCT on top of CT selectively in about 20% of cases, what we found is that the referral to the cath lab is enriched. This is from the advanced registry, over 5,000 patients. The PCI to ICA ratio when referred to the cath lab in the setting of stenosis and abnormal physiology was 83%. You compare that to CT alone in most databases, about 60%. You compare that to stress testing, about 40%. So it enriches the referral to the cath lab. It also, I think, helps us identify patients for whom revascularization is not needed, where they will likely get adequate symptom relief from medicine alone. In 1,600 patients with negative FFRCT and an anatomical target, only 6% of those patients were revascularized out to a year, and the majority were done early because of historical, perhaps, reliance on anatomy. But if you left the patient after 60 days with an anatomical lesion but negative physiology, only 1% crossed over, requiring revascularization owing to refractory angina. And then finally, as it relates to heart events, as we've seen in the invasive world, very low cardiovascular mortality and MI rate in the setting of a negative FFRCT, 3 events in 1,600 patients. Those data are being expanded now out to 5 years, over 7,000 patients in a meta-analysis led by Bjarne Norgard, which is, I believe, under revision in heart. Finally, I wanted to highlight before we pivot to planning intervention, which should only take me 10 minutes, I hope, is that in the randomized trials, invasive FFR is, of course, a binary cut point. I'm struggling. A binary cut point. You know, you can't randomize across a non-binary cut point. But we know in clinical practice, actually, from Niels Johnson, who I believe is from Edmonton, did undergrad at UBC, and he's with Lance Gould at Memorial Hermann. He's shown us that as the FFR goes down, the event rate goes up significantly, and the benefit of revascularization goes up as well as the FFR goes down. Well, we've seen the same thing from FFRCT, except for in FFRCT, what we've seen is that from Abdul Adahid in the 5-year NXT data and Manesh Patel from the 1-year data, the lower the FFRCT, the higher the risk. And then recently, actually 2 weeks ago, from Professor Koo from the 10-year outcome of Discover Flow, look at this very figure. The almost exact same figure, obviously much smaller cohort. You could see that as the FFRCT goes down, the risk goes up, and the risk associated with deferral goes up drastically, and the benefit of revascularization also goes up. So in clinical practice, we don't use this tool in a truly binary way. We know that an FFRCT of 0.62 is much worse than an FFRCT of 0.79, which is nominally worse than an FFRCT of 0.81, even though it's across the binary cut point. Sorry. So before I pivot to planning intervention, people ask me about the cost effectiveness of this pathway. There is some analysis of PROMISE trial. It was a modeled analysis from the MGH group, which showed that FFRCT was dominant over CT alone, which was dominant over functional testing. But this is observational. There's a randomized trial that finished enrollment a month ago, almost to the day, led by Pam Douglas, which will be very important, called PRECISE, which will be needed to really, I think, inform us in understanding how to use this tool in our practice. 2,100 patients. The outcomes will be available likely for ESC 2022. I know that you do a lot of work in the field of microvascular angina, so I wanted to highlight one other opportunity from this computational modeling, and this is this concept of VM, this concept of coronary volume to mass. The idea that if you have low coronary volume to mass, that your myocardial flow as it relates to the myocardial demand will be modest. And it takes very little atherosclerosis in that setting to actually have abnormal physiology. On the other hand, if you take Johnny Goudreau and you gave him atherosclerosis, but he trained all his life until that point, he could accommodate that atherosclerosis without abnormal physiology for quite some time, because I would imagine his coronary volume to mass would be extraordinarily high. And so actually Tim Fairbairn looked at this between men and women in the advanced registry, showing that while women generally have smaller coronaries, their coronary volume to mass is higher. And that higher coronary volume to mass, I would argue, may be evolutionary as it needs, based on the needs to accommodate pregnancy. But this is actually a better flow state. But if you did have a woman with low coronary volume to mass, you would imagine that she would be at risk of having abnormal physiology. And this is actually what we saw as a result across all thresholds of stenosis, because women had higher coronary volume to mass, they had higher FFRCT values because their resting flow is better, their FFRCT values were higher. But what we can also look at is across the nomographic distribution of this concept of coronary volume to mass, that patients with high VM are almost impervious to stenosis. Their FFRs are high despite anatomical lesions quite often. On the other hand, it takes very little in the way of a focal anatomical target to have abnormal physiology in the setting of a low VM. So I wanted to close in the final few minutes about where I think the field is going. You know, we wouldn't go at Foothills or at St. Paul's, and we wouldn't do a TAVR without a non-invasive assessment of the annulus. But yet we see patients routinely going, at least historically at my site, and I'm sure at yours, to the cath lab on the basis of this paradigm, only for the interventionist to find no plaque, or perhaps worse yet, she finds sinister atherosclerosis with an end-STEMI waiting, and she has to make ad hoc decisions around revascularization. And as we saw at ACC this year, but we've seen historically, that this leads to incomplete revascularization. In the ischemia trial, incomplete revascularization occurred 40 to 60% of the time. In the syntax trial, it was 30%. And we know that this incomplete revascularization is associated with a worsened downstream outcome. So can we actually use CT to help this? I don't have evidence that it will actually reduce incomplete revascularization, but it sure makes a lot of sense to me. If you've already done the CT, why not explore it to give more information to our interventional colleagues to help plan that intervention? This is from Nico Piazza and a group from Poland, looking at using CT to identify fluoroscopic angles to optimize left main profiling or left main bifurcation in a fashion similar to TAVI. And we can do this routinely so that we can actually provide angles that are personalized and helpful in optimizing revascularization. To that end, I don't know why this is showing. This is from OLV in also Belgium. You can see as we rotate this, we're providing fluoroscopic angles. And why would this be important? Well, if you just went to the working angle from the cath lab where you typically would work, you can appreciate that the lesion would look 3.6 centimeters. But in this case, Carlos Colette used the CT-based angle. And what did he find? That the lesion is actually significantly longer. So optimizing fluoroscopic profiling of the lesion is essential to ensure complete revascularization. We also know CT can provide you plaque morphology, understanding or helping us understand if we have heavy calcium and when you may want to go into the lab prepared to encounter a heavily calcified lesion. We know that lesions are never the same, and therefore this understanding of patient-specific anatomy can help you understand perhaps potential risk of embolization or, again, need for lesion catheterization. I would also posit to you that the days of going to the cath lab and having unpleasant surprises of critical left main could be behind us, that we could be diagnosing these critical left main lesions on CT. And finally, what are the opportunities of anatomy and physiology? Well, the first insight that we got from this comes to us from Syntax 3 and Syntax 2 from Patrick Sirois, where he showed us that when we looked at the non-invasive anatomical syntax from CT and compared it to the invasive gold standard, that CT overestimated the disease burden. But when he actually looked at the functional non-invasive syntax, the roadmap from anatomy and physiology, it agreed quite well with the anatomical gold standard, suggesting that you could actually go to the cath lab with an understanding of the complexity of the anatomy and physiology with a plan for potential revascularization of some lesions and deferral of others. To that end, you can see a high-grade lesion in the LAD. This is so high-grade, you could probably just go and plan to revascularize the LAD. But there was a moderate to severe right coronary lesion. The FFRCT was done. It was negative physiologically in the right. This patient could go with the intention of revascularization of the LAD and deferral of the right. And here's the corresponding invasive angiogram. Beyond that, I think that it can help us really understand which patients are not going to derive benefit from revascularization. And so I'll close with this concept of the phenotype of physiology. Here you can see invasively, the angiograms look very similar to my untrained eye, but when they do mechanized pullback and they do these pullback curves using hyperemic pressure, you can see that these hyperemic pressure curves are very different. The x-axis is length, the y-axis is physiology. Here you have very normal physiology and it drops like a stone. This undoubtedly can be treated very nicely with focal PCI because of the very focal phenotype of physiology. On the other hand, this is a very diffuse pattern with abnormal physiology, but without a focal translesional gradient. Well, we can generate this, of course, non-invasively now and really characterize this pattern of morphology of not only anatomy, but physiology, and really try to refine our understanding of who is going to derive benefit from revascularization. And so to close, here's such a clinical case, diffuse plaque in the LAD. You can see this non-calcified, positively remodeled plaque, some calcified foci, clearly long disease, long plaque, long lesion in the LAD with a wraparound LAD. Here's the non-invasive physiology, 0.67, 10 centimeters out, 0.73 virtually, but you can see no translesional gradient, no focal delta that would suggest the patient is going to have a significant improvement in physiology with PCI. And sure enough, look at the post-PCI physiology. Extensive remodeling of the anatomy, almost no change in the physiology. So I'll close there because I see we're at 7:46. There's so much more we could talk about. Obviously, I need evidence to suggest that planning intervention with CT is going to improve outcomes. There is such a trial called P4, which is beginning enrollment. It's a daughter trial of P3, which was just presented at EuroPCR, which I didn't have a chance to touch upon. But these sorts of trials will be very important to see if we can really explore not only using CT for diagnosis, but for treatment planning in a fashion that will improve clinical outcomes. So thank you for the opportunity. I hope that was of interest.
That was a absolutely fantastic talk. Carlos, did you want to field the questions or did you want me to?
Go ahead.
So while people type in questions, I just wanted to take the chance to ask the first question. So you've shown us lots of data that there's different prognostic things that we can look at by cardiac CT, like either number of plaques, high-risk plaque features, plaque volume. How do you integrate all of that into your reports so that the people getting the reports understand what you're trying to tell them?
This is a very good question. So CAD-RADS is being iterated. So CAD-RADS 2 is under revision. And in CAD-RADS 2, there will be an element around plaque. Right now, as you know, in CAD-RADS, it just has a rider with V, vulnerable, which requires a single lesion with positive remodeling or low density plaque. If present, it should be recorded. One of the things we've struggled with, as you know, is that if you right now, if you issue a CAD-RADS report, I could say CAD-RADS 1. That means that the most severe anatomical stenosis is less than 25%. But as you know, in your practice, that I can have a CAD-RADS 1 with seven segments of plaque, right? I can have a CAD-RADS 1 where we're sort of debating, is there even plaque, in a single segment? Those patients have very different risks. We've seen that in CONFIRM, right? There's a dose relationship between the extent of plaque and risk. And so I think that's obviously very, very important to keep in mind. In the new CAD-RADS, it will actually include a descriptor based on the extent of plaque. So there'll be 3 levels. I forget what was settled on there. I'm not focusing on the plaque element, but I think it's mild, moderate, and severe burden of plaque, because we know that's important. The other element that's important, of course, is if the plaque is premature. And that is something that, I think we've struggled with because we don't have good nomograms for CTA as to when is it early. We published a nomogram from CONFIRM back in CIRC imaging in 2016. But beyond that, I think we can look at the calcium score if we have it to provide us an assessment of whether the plaque is premature or not. But these are the sorts of things, I don't know if I answered your question, but these are the sorts of things that we need to start really emphasizing, right? What's the most severe lesion? Is there adverse plaque? How extensive is the plaque? Where is the plaque? And do we think the plaque is premature?
Yeah, no, I think that's really helpful. I'm just going to break down one of the questions from one of the fellows. And the background is the cardiologist here is still using a 64 slice cardiac CT scanner. So his question is there a cutoff for calcium where you proceed with the CCTA versus just doing a calcium score only? And would you have a cutoff if you were using a 64 slice scanner instead of I think you're using a Revolution, right?
You know what? We use a cardiograph and Revolutions. The cardiograph is a small footprint dedicated cardiac CT. To answer your question, there's no calcium score that we defer CTA on. We will proceed with CTA unless the patient, unless the patient has a higher heart rate and is obese and has a high calcium score. So if we can't get that heart rate down and has a very high burden of calcium, then I think we probably are just doing harm, right? But if we can optimize image quality otherwise, I don't think that's a concern. I think we can do it, and I think we can do it well, especially if we do it thoughtfully and we understand why we're doing the test, right? I think that if CT serves solely as a gateway to the cath lab, if you're going to send every patient and their sister to the cath lab for every moderate lesion and you overestimate stenosis or you have inexperienced readers, then I would say not. But I know who your readers are, and I know the type of practice that you have, and I know the integration between cardiology and radiology, which allows for really good collaboration. I think that you can do CTA in that setting, understanding that there's going to be some limitations. But again, if we have a very high calcium score, we really make sure that we get that heart rate very low. And in addition, that we make sure that we have good nitroglycerin usage. We use 2 sprays. We wait at least 5 minutes. And we always use 120 kVp in the setting of calcium. If I even see any calcium, our techs are requested to uptitrate dose from 100 kVp to 120 to prevent partial volume averaging or blooming.
That's great. So question from Andrew Howarth. In an environment where CTA is available and reliable, what do you see as the role for perfusion imaging?
Yeah. Listen, PET is different. And, we've had we're desperately trying to get cardiac PET access here. And I think SPECT will still play a role, particularly in patients with known disease, particularly obviously for other indications. I think PET has a tremendous future as it relates to coronary flow reserve and microvascular assessment, as well as infective endocarditis. We're exploring it with a group from Edinburgh as it relates to valve degeneration, looking at sodium fluoride and other tracers, thrombus tracers for valve degeneration, and then obviously plaque characterization. If you ask me, do I think that a SPECT should be considered as a first-line test versus CT? No, but that's my opinion. I think the data supports it. I also don't think we should be doing CT on patients with known disease frequently, except for in very rare occasions. So I think once you have known disease, I don't think we should be doing CT unless it's for very targeted specific requests. So I hope I haven't made too many enemies, but.
No, I think that's fair. Go ahead, Carlos.
No, so what about the standard exercise treadmill test that people do every year?
Yeah.
Someone has a little bit of chest pain. Are we ever going to get rid of that, or should we get rid of that? What's the best choosing wisely strategy to implement this?
Well, it's a really interesting point. And I think in the capitated ration healthcare system where we have wait times, I think many of my clinical colleagues have used this treadmill and the stress test to really determine whether they need this CT more urgently, actually. If there's suspicious findings, if there's angina, I don't need to explain to you, you could explain to me, but if there are high-risk features on the treadmill. And then one thing that my very wise clinical colleagues remind me, and I preface it with the fact that, I don't manage the care of patients. So I'm not you guys should be telling me, those of you that do this, but they remind me importantly that understanding patients' exercise tolerance is very important as it relates to follow-up, right? Are they deconditioning? And maybe not so much as they remind me, they don't do the treadmill to determine whether there's an LAD stenosis, but to get a sense of overall exercise tolerance, which we know, going back to the 70s, is a predictor of mortality. So, actually, it's funny you should say that, but I submitted an application to the ischemia trial as part of the CT Core Lab to look at that exact question. Does exercise tolerance and does the treadmill provide prognostic information beyond the CT anatomical burden? We know that it doesn't as it relates to the electrocardiographic findings. At least we know it doesn't from a couple of important papers from Korea and Italy. But what we don't really know is, does just simply METs or exercise equivalence, is that still important in predicting risk? In other words, if you don't have severe coronary disease, but you have poor exercise tolerance, are you likely to do poorly, or is it just or not? So I think that will be helpful to answer that question a little bit, at least.
Yeah, the other thing is that you showed some really compelling stuff on the physiology. So should that be kind of like the standard of care when you report a CTA?
I mean, again, I don't know about standard of care, but I would say, it's now being used in the majority of centers in the US. And I do think advanced analytics, as we see, from your team in the MR side and certainly, on the CT side, whether it's plaque, whether it's some of this VM, which I think will be really important in helping us understand why some women have angina despite a lack of anatomical target. I think this coronary volume to mass may be a very important measure. And then I think the physiology is important in refining our understanding of who's going to derive benefit of revascularization. So I think that it is something that, I know that it's being evaluated by our ministry here. We've used it as part of a research agreement and then a subscription for years. And I know in Ontario they are as well. So I think there are going to be many advanced analytics, and we have to find a way how to make these accessible in a cost-effective way in our Canadian health system.
Well, thanks, Rob. Anything else to add?
No, again, that was a absolutely fantastic talk. So thanks for joining us this morning.
My privilege.
Yeah, agree, Jonathan. Thank you very much. It was
great.
And have a great day, everyone.
Be well, stay safe, and look forward to seeing you in person sometime soon.
You bet. Take care.
There.